Hi, I'm Rui Pereira Costa, organizer of the Endomasters 2015. From Romania, the leading country in participants of this World Online Congress, I'm honored to present to you my friend Roberto Cristescu. He is a postgraduate in endodontics from the Endodontic Postgraduation Program at ACTA in Amsterdam, the Netherlands. He currently owns a private practice in Amsterdam limited to endodontics. Roberto has published articles related to endodontics in the Journal of Endodontics, Quintessence, Oral Health Magazine, and others. His lecture today will approach a real hot topic. Roberto will discuss and bring us everything about access cavities and their relation to the long-term prognosis of the endodontic treatment and survival of teeth. I'm sure you'll enjoy. See you soon.
Hello everyone and a warm welcome to the first edition of the first International Endodontic Congress Endomasters 2015. My name is Roberto Cristescu. I'm an endodontist specialist in Amsterdam, the Netherlands, and associate clinical teacher at the Warwick University, United Kingdom. The title of my presentation today is The Access Cavity and its characteristics that may affect the outcome of the endodontic treatment. I wanted to start here with a balance between two pictures representing actions which we hopefully are capable of doing on an everyday basis, to read and to see. In a normal way they exist together, blended in harmony, but there are also specific moments and places when we get the feeling that they are actually antagonists and they are fighting to each other. And I will try to explain this in the following slides. How many of you are already familiar with the classical saying that a picture is worth 1,000 words? It is clear, it is famous, we do like pictures, we like to see. It is easy, fast and fascinating. But is it also enough? Well, of course, it depends on the picture. Here you have a piece of art picture in dentistry, quite recent and also very often reproduced by a lot of practitioners all over the world. In case you still don't understand what it is, I will tell you. Those are water bubbles on the Teflon. And pretty much that's it. You do not know exactly which tooth it is. You might guess it is a central incisor in the upper jaw. You have absolutely no idea what the diagnosis of this patient is and also really no clue whatsoever about what is a dental treatment that it will be performed here. So, by admiring such an artistic view, can someone really explain in 1,000 words what is its idea and its meaning? On the other hand, related to my topic today, there is a very solid study which was published in International Endodontic Journal. It is a systematic review that wants to say like the creme de la creme of the best articles published in the recent history of endodontics. And it is about tooth survival of endodontically treated teeth. And believe me, it has no more nor less than 14,271 words and really no picture. I urge you all to read this article and you will understand why, if not always, at least almost always, reading 1,000 words means more than just looking at one picture, especially if it is not really well chosen picture. So what I will try to do with you today is actually to simulate reading by seeing, but not only just seeing with your eyes, seeing and processing information with both the eyes and the brain. And not before I really go into my topic, just to make it very clear, I do love Teflon, but I also love it when placed in the pictures that really want to transmit something, of course related to our profession, something which is meaningful. Even in that particular case, no rubber dam was used. So I will just grab my colors and my chalkboard, just like we used to do in school, only of course now we use computers and the World Wide Web to connect to each other. And I will go on. And before beginning to see how an access cavity should be performed and what characteristics might influence the outcome of the endodontic treatment, it is of utmost importance to start with the causes of the endodontic pathology. So far, at this moment in time, we do know that endodontic pathology which requires a root canal treatment procedure is caused mainly by bacterial infection that arises from a direct pulp exposure due to cracks, caries, trauma, or from a direct dentinal tubuli exposure due to several factors like caries, fracture, marginal leakage, cavity preparation, root planning, or even root resorption. On this slide, we can see that almost all causes of endodontic pathology have an entry port into the root canal space into the coronal part of the tooth, and that's exactly where the pulp chamber starts and where the practitioners performing the endodontic treatment will make their access cavity. On these slides, I want to represent characteristics of most of the teeth which require a root canal treatment procedure. As we are all aware of, most teeth needing root canal treatment have either deep decay, deep and large coronal restorations, like filling, onlays, crowns, bridges. Here are also some clear images of how most of the teeth needing a root canal treatment do look like in their coronal half. Nevertheless, in the last 4 to 5 years, we are exposed to articles, presentations, online posts of cases which are endodontically treated through a conservative endodontic cavity, where the whole of almost the whole crown is intact without any evidence of decay or coronal restorations. And before beginning to analyze in a comparative way the two types of concepts, I need to rebrief for you in 2 short slides how science is performed in the endodontic field. Direct outcome studies. What we actually look at what happens with existing teeth in alive patients after we perform a root canal treatment. I try to show you here in a graphical mode what a direct outcome study means. We have an infected tooth in a patient's mouth. As a result of the infection, this patient developed an apical lesion. Now, after we perform a specific root canal treatment using specific instruments, materials, methods, we will recall this patient and we would like to know, for example, if the apical lesion healed. This is what I call a direct outcome study. In comparison, a surrogate outcome is based usually of studies using extracted human teeth, which we infect, on which we perform a specific procedure like shaping or irrigation or obturation, or all 3 of them. And afterwards, we are trying to inspect different parameters of the intervention we performed, like looking with a live dead mold electron microscope if there are still bacteria in the root canal system, or if the dentinal tubuli are open and clean, also on an electron microscope study. Or we look how much % of gutta-percha we have filled after we fill the tooth. Or we use microcomputer tomography to calculate how much root canal surface we touch with our instruments. Well, unfortunately, it is very hard, or actually until now impossible, to find a direct real correlation between those parameters that we measure in extracted teeth and the actual healing of the apical lesion in an alive patient. When we talk about direct outcome studies, the real outcome consists actually of 3 parameters which we do study. If there is any postoperative pain, if the apical tissues heal or not, and if the teeth manage to survive or not, and for how long. Nowadays, we face a new shift in the design architecture of the access cavities of the teeth which require root canal treatment. The term has already a name, and it is called minimally invasive endodontics. And from that on, we do have the term conservative endodontic cavity. Basically, I will try to illustrate here the shape of the 2 access cavities in a lower molar. Left, you have the traditional one, the classical textbook access cavity design, and on the right side, the new concept design with an evident minimalistic look, sacrificing less tooth structure. Regarding the postoperative pain factor, we do have around 195 studies with their drawbacks and flaws we have to recognize, showing what type of answer we might expect if we perform a root canal treatment with a traditional access cavity. Either we talk about emergency treatment or a complete root canal treatment. So far, we do not have any single study in humans showing what we can expect if we perform a root canal treatment using this type of access cavity. Just shortly mentioning here a study from 1989, very well designed, a controlled randomized clinical trial for emergency treatment in visal teeth using a pulpotomy procedure which we do know that it has a high success rate regarding postoperative pain, no matter what type of medication was used in the pulp chamber. Well, this type of study was done using traditional access cavities and not a minimalistic one. So at this moment, we do not know if using a different access cavity than the one showed here, we can have the same answer regarding lowering the pain complaints of the patient. And same it goes for the non-vital teeth, this time with a systematic review of the literature. And here, needing to repeat myself, at this moment, not a single study in patients showing any result for the postoperative pain factor using this type of excess cavity, neither in pulpitis or apical periodontitis cases. The next big factor studied by the means of direct outcome studies is the capacity of healing of periapical lesions. We do have so far to compare 119 studies, again, obviously with their big drawbacks and flaws, to just 0 outcome studies with treatments performed by using a minimalistic endodontic cavity. Recently, it was published an outcome study from United Kingdom with cases done by one single endodontic specialist in ideal working conditions, looking at the results obtained both on the bidimensional or three-dimensional radiology, and this by using just a traditional excess cavity, with the results 98% success on normal radiograph and 82%, so lower percent, on CBCT outcome. Already, the classic systematic review from NG with healed cases using either radiographic and clinical factors. All those studies were done using a textbook classic excess cavity, if not larger, maybe enlarged ones, because most of them were done without the use of microscope. Again, absolutely no data whatsoever for the conservative approach. The last factor, and probably the most important one for the proponents of the conservative approach, survival of the teeth. Again, with their drawbacks and flaws, with their short or just medium recall periods, there are about 125 studies showing the survival rate of endodontically treated teeth using a normal classical excess cavity design, and we have 0 for the other option. In an epidemiological study, so not so high on the pyramid of evidence as I show you here, we got around 97% survival rate at 8 years for almost 1.5 million of teeth which receive a root canal treatment procedure. In the top of the pyramid of evidence-based dentistry, a systematic review showing survival rates between 86 and 93% for teeth treated in the classical traditional way. Again, just like in the other parts, absolutely no study in human patients showing what is the survival rate of those teeth treated with a conservative approach. So, after all, what does matter for success? According to the best evidence so far for gaining a higher success of the endodontical treatment, clinically and radiographically, we seem to have those 4 factors. I will try to emphasize the 4th one, good quality coronal restoration, which seems to play an important role for the endodontic treatment in the whole, so not only for the survival rates. What do we need to increase the survival rates of endodontically treated teeth? Well, again, a systematic review showing already 4 factors which are more linked to the type of coronal restoration and the occlusal forces and not per se with the amount of tooth structure left. We have a crown restoration, we have tooth having both mesial and distal proximal contacts still available, tooth not functioning as an abutment for removal or fixed prosthesis, and tooth type or specifically non-molar teeth. Then the next logical step is to ask ourselves, why such a conservative endodontic cavity approach, without any proven benefits so far? Well, first of all, it serves a good cause, and nobody can blame this, preserve the dental tissue of the patient. But I would like to stress here something very important, that we need to realize that we do need to preserve the healthy dental tissue of the patient and not the decayed, cracked or necrotized tissue of the tooth. So far so good, we like this idea. Unfortunately, the only data we do have regarding this approach is a surrogate outcome study. It's one ex vivo study showing on micro CT that besides the distal roots of lower molars, we clean the root canal space as good or actually as bad as with the traditional excess cavity, and that the resistance of the teeth opened with the conservative approach is higher if we apply static pressure on different load points. All of this on extracted teeth in the laboratory. There are 2 crucial factors I want to mention and highlight here for people which did not have the time to read carefully this article. Point 1. All the excess cavities were not restored. What type of external validity might have such a study? Who and when is leaving excess cavities completely empty in treatment of the patients? And to make it more questionable, we do have also data like this study in the effect of tooth structure loss and restorative technique on the fracture resistance, showing that Just by restoring with composite the mesioocclusal or the mesioocclusal distal cavities, their resistance increases with 50%. So yes, it really matters if the excess cavities are properly restored or not. They claim that this type of conservative access should not be a problem for the instrumentation of the root canals by quoting 2 laboratory studies about the mechanical properties of just one rotary file. I think we all do agree with the difficulty of accessing, cleaning and shaping a root canal system does not rely on the mechanical aspects of just one single rotary file, and we are dealing with the patient, the dentist, the instruments, irrigants and obturation factors. Besides the ex vivo study of surrogate outcome, we also have some expert opinion articles published in Dentistry Today. Those expert opinions are valuable, highly recommended to be read and analyzed, but not forgetting that on the pyramid of evidence they are really on the lowest level. Just one example of what an expert opinion article might do: when in 2013 the authors criticized an excessive coronal enlargement of an endodontically treated premolar, suggesting this might have a negative influence on the prognosis of the whole tooth, which seems logically if we agree that we might get similar endodontic results without removing so much of the dental tissue. Well, just 1 year later, the clinician who performed the endodontic treatment answered with another expert opinion article in the same journal, showing a beautiful 27-year-old recall, showing excellent radiographic appearance of the bone surrounding a surviving tooth which was properly restored. Another expert opinion article suggested that one tooth exhibiting enlargement of the lumen of the canal, using a CBCT axial slice and comparing this second premolar with the first premolar, suggesting that the first premolar was not having such a big diameter of the canals, which induces the idea that the bigger lumen in the second premolar is caused only by using a Gaze-Glidden burr. We should be very careful when we take those comparisons, because we have to realize that teeth have different anatomies and also different dental histories. A first premolar, even intact, might have a much bigger lumen of the root canal than the second premolar. Another tooth with an extensive coronal restoration might have also smaller root than the others. Or even the same tooth, you can have completely different anatomies, like you can clearly see in this endodontic treatment, where very little active shaping has been performed. The palatinal root canal was obviously more large and wide compared to the very thin buccal canals. Last but not least, doing such a conservative excess cavity, clinicians can hire the ego of a radiographic beautiful treatment, which shows extremely high technical skills. How much healthy tooth structure does such an excess cavity save? It is very hard to impossible to quantify. Most of the time we can only look at bidimensional radiographs like here. Still, thanks to a recent study using computer analysis of the volume of the tooth loss during an endodontic treatment and also afterwards during post-preparation, it seems that in those type of premolars, removing the decay means 8% volume loss and really making the excess cavity only 4% extra volume loss. And also do not forget, this is not a conservative excess cavity. In the end, I would like to show you two normal endodontic cases routinely seen in an endodontic office and trying to highlight some aspects we need to take care of when we perform an excess cavity and when we do restore a tooth. The first case, this is a lower third molar, which we initially saw incidentally with complaints of irreversible pulpitis. At that time, we advised the referring dentist to provide a new coronal filling, replacing the old amalgam. The patient was in our office for the retreatment of the second molar. After 1 month, the patient was sent back to us with irreversible pulpitis complaints after the dentist changed the amalgam film with a new one using composite resin. This was the new clinical situation. This is what we saw after we started the endodontic access. We clearly can see signs of leakage still present and obviously cracks which are present in the whole coronal structure. This is a conclusive view with the affected dentin. And finally, after managing to gain access, the red bleeding inflamed pulp tissue. image during the root canal procedure with all 3 canals being shaped and clean, finally filled with gutta-percha and sealer. And you can notice the fact that on such an access cavity, we are able to inspect all the walls of the pulp chamber cavity so that any signs of crack propagation are excluded. After the endodontic procedure is done, we also place the buildup, also using composite resin, but first remove all the affected dentin and all the visible signs of the cracks, knowing that they do not extend into the pulp chamber or into the root canals. Lowering the cusp height in order to provide the necessary place for cusp coverage material. And the buildup placed. And the final radiographic results. A second case, also of irreversible pulpitis, this time in the first lower molar. This is the bite wing picture, which shows a very nice adapted mesio-occlusal distal composite filling. This is the periapical radiograph of the tooth, and from another angle, it seems like the normal, usual case of irreversible pulpitis due to deep cavity preparation, especially close to the mesial pulp horn. This is the clinical picture, and this is a stage of the access cavity preparation with an occlusal view already showing decay under the composite resin. Inflamed tissue in the pulp chamber and leaking composite resin on the mesial wall of the access cavity. As we should all be aware, leakage cannot be measured by radiograph, at least not in full extent. And by the way, not even with a dental operating microscope. Hard bleeding inflamed tissue in the pulp chamber. And at this moment, you can see that the roof of the pulp chamber has not been completely removed, which will still leave a mess of pulp tissue remnant in the particular space. We have no guarantee that the irrigants used will be able to dissolve that tissue. And it is not the same issue as with an apical pulp tissue, which is left by the so-called pulp lover dentist, because in this case, that tissue will become sure necrotic as it will lack the blood supply after the endodontic treatment. Clear view over the mesial root canal system, managing to inspect for the presence of middle mesial canal, and also with ultrasonics troughing the isthmus. Same goes for the distal root canal system with 2 canals, and also note the presence of the pulp stone. The working length determination, the intermediary phase during cleaning and shaping of the root canals, filling the mesiobuccal and mesiolingual canals. You can note clear view of the isthmus. Distobuccal and distolingual canals filled and the pulp stone already removed. And then, here we have the real view of what was actually happening distal and mesial after we completed remove the old composite resin. Both mesial and distal parts of the tooth were showing large areas of affected dentin, and this information was not possible to be taken from the periapical or the bite wing radiographs. We performed gingivectomy, we placed matrix systems, we see the mesial margin very clear, the distal margin as well, we build up the mesial wall, we're starting the occlusal build-up, and we finish the restoration. And this is the restoration in place, with occlusal marks, and here also. And the final post-op radiograph. This case, together with the first one, illustrates the fact that we miss a lot of information just basing ourselves on the preoperative radiographs, and the access cavity is a mean not only to get access to the root canal system and to perform a good quality endodontic treatment, but also a very useful space to get information about the coronal state of the dental tissues. Presence of cracks or decay. It is obvious that both cracks and decay are a negative predictor for the outcome of the endodontic treatment. And at this moment, I would like to illustrate my presentation with 2 endodontic cases where I personally managed to access the root canal system through a conservative access cavity, and we will go through the phases of this procedure. Case number 1. A first upper molar presenting with irreversible pulpitis symptoms and 2 different composite resin fillings. We have the preoperative clinical picture, and after realizing the access cavity, the bleeding pulp tissue. The red color line showing the entrance in the mesiobuccal 2 root canal. So at this moment we can actually see that even the second mesiobuccal canal can be identified, despite the small dimensions of the opening which was created at the occlusal surface of the tooth. A special view is created while bathing the pulp chamber with the normal irrigants through the optical effect, which allows us to see all the three entrances in the mesiobuccal, mesiobuccal 2 and distobuccal canals just in one straight image, looking from above the level of the excess cavity entry. It is also possible to see where and how deep the irrigant needle is penetrating the root canals. The difficulties arise not only from not being able to inspect the lateral walls of the pulp chamber, so not being able to rule out any signs of decay or cracks, but also, as here shown, the amount of stress placed by the tooth structure on the rotary instruments which we use for the step of cleaning and shaping of the root canals. Lack of view with more pressure on those fragile instruments is a risk factor for increased file breakage. Another possible drawback is the fact that due to its limited size, you cannot always place all the four gutta-percha cones in order to check it radiographically that everything is exactly as it is supposed to be. Of course, that if that extra step and extra radiograph would be justified by the real data that this type of access will really prolong the lifespan of the tooth on the arch, probably all those extra efforts and extra radiation will have a good meaning for the end result. Here's a picture where you can clearly see the mesiobuccal and mesiobuccal 2 entrances. You can still see a palatinal canal with a pulp stone which will be removed, the distobuccal canal entrance, mesiobuccal and mesiobuccal 2 canals which have been filled, distobuccal also obturated with a palatinal, and of course at the end restoring the excess cavity opening with a composite resin filling. And this is a postoperative radiograph from one angle, direct angle, and from the distal with two portals of exits for the two mesiobuccal root canals, with a nice apical hook of the distal root canal which has already been filled. Case number 2. Also a lower molar with irreversible pulpitis pathology, which presents in the coronal part not only a composite filling, but also, you're going to see here, some sort of cracks and grooves which seems to have been already infiltrated. Those aspects have been extensively discussed with the patient at the moment of the consult because they can clearly have a huge influence on the outcome of this tooth. This is what is called a step access, with removal of the occlusal composite but a very limited opening through the dentin structure above the roof of the pulp chamber. Again, this case as well, presenting a sort of pulp stone attached to the buccal wall of the pulp chamber, which has been removed with the aid of the ultrasonic tips. A clear view over the mesiobuccal and mesiolingual entrances, but also the isthmus between them. Both mesial canals filled with clear view of the isthmus. Distal canal filled. Lingual crack is removed until healthy dental tissue, like here, and the tooth is restored by means of a composite resin. Lingual view with the affected tooth structure replaced by composite resin, so no more cracks present in the tooth. Post-op radiograph with an evidence of the limited excess cavity, but also voids in between the flowball composite and the gutta-percha from the mesiobuccal and mesiolingual canals. Yes, the question then remains, what are the risks if we change our approach of accessing the root canals? Here we have a case of my colleague and friend Rafael Michiels from Belgium, where he managed to treat very nicely premolar through a conservative excess cavity. Just to show at the end, if you will remove the whole old restoration, you will be able to find something which was not possible during the root canal treatment, leakage on the mesial part of the tooth. Also from Rafael, another case, in a molar with a severe coronal curvature in the mesiobuccal root, where probably due to limited excess cavity made into a porcelain crown, the rotary instrument separated into the mesiobuccal 1 root canal system. Of course, an attempt to remove such a long piece of an instrument would have meaning destroying almost the whole root structure, which obviously was not wanted and also not performed. The mesobuccal 2 canal was treated accordingly, and on the postoperative radiograph we see that the two canals of the mesobuccal root are joining. This is Oskar von Stetten, a great friend and fantastic colleague from Germany, showing, not in a conservative access cavity, what can happen if we leave decay in the medial part of the tooth. Because, isn't it so, we heard already too often that if we will not mechanically remove debris in the pulp chamber, the irrigants will do this for us. Which, bingo, it works. As you can clearly see, the decay was neutralized by the means of the powers of sodium hypochlorite. Well, actually not. Obviously, just as Oskar managed to show here, after removing the white spot of the modified dentin and finding still decay and still a crack underneath. Those are my two cases. You saw them already, both with voids which we consider too often not relevant, and we like to think that they do not matter for the outcome of the endodontic treatment. Voids into the palatinal canal on the right and into the pulp chamber on the left image. Obviously, through the small access, it is so much difficult to keep the focus and actually even bring the materials where you want with a high level of precision. Missing canals can be another drawback of this accessing the root canal system. Just like you could miss the second palatinal canal here if you will limit the vision of the floor of the pulp chamber. Well, you can miss them only if you don't have a CBCT, because otherwise, of course, we all know that you can see that extra root. The matter of not cleaning properly the pulp chamber has not yet been very well studied. We know, as already said, the pulp chamber floor communication with the furcation area. But even the pulp horns can still hold necrotic material, possibly fully packed with bacteria cells. This is a micro-CT image from the Brazilian group of Professor Marco Versiani, published on his blog, the Root Canal Anatomy Project. What can you gain by doing such a conservative access? Exactly. As previously mentioned, you can differentiate yourself as a highly skilled endodontist if performing such a limited access cavity and still be able to negotiate to full length the root canals. After all, the primary impression of a referring dentist is not about the amount of irrigation or disinfection one endodontist has achieved, but about the look of some postoperative radiographs. Nowadays, when we are using digital image to document our cases, it is more than evident that this will allow also to get another convincing factor to penetrate the referring dentist base. The teeth are not destroyed by the endodontic access. If we can make the teeth more resistant to fractures or cracks, we still do not know yet. It is obvious that a tooth with more structure saved can just only be stronger. But if this automatically translates into a higher survival rate of that particular tooth, we do not know at this moment. But if we talk about extractions and fractures or cracks, are all endodontically treated teeth extracted because of those reasons? In a recent prospective study from 2011, it has been shown that about 60% of the reasons for failure were of endodontic or periodontal reasons. The two results that might have been caused by the lack of enough resistance of the tooth structure are 12% for vertical root fracture and 15% unrestorable cuspid and crown fractures. And obviously, another question which might appear: do those cracks or fractures appear only in endodontically treated teeth? No, the answer is obviously no. Yes, in 60% of the cases with teeth with vertical root fracture, we do have also endodontic treatment present. But those cracks can also be found in teeth that never received an endodontic access cavity or an endodontic treatment. In the review article about the risk of fractures in endodontically treated teeth, the authors came to the conclusion that the central role in the appearance of those cracks and fractures is played by the coronal restoration of a tooth, independent if the tooth is vital or not. If there is no cuspal courage, or if the restoration is temporary and still in place for a longer time than expected, the risk for cracks is much higher. In conclusions, I want to stress that the access cavity not just that dictates the technical steps of the endodontic treatment, but also the outcome of this treatment. A conservative endodontic cavity is serving a good cause, but at this moment in time, without any single proven benefit for the outcome of the endodontic treatment or of that specific tooth. Despite the lack of direct outcome data, probably conservative excess cavity will become the norm for a vast majority of endodontists. That does not mean we can do this. Of course, I don't want people to think that now, without data, we can start an endodontic treatment just like this. Huge perforation, a pocket of 10 mm on buccal side, which was actually managed to be treated. With a very good result at 5 years, the tooth is asymptomatic, stable in the mouth, and the pocket reduced to 4 mm. I thank you all for all your attention. I hope I'm going to see you in Amsterdam, and good luck attending also the other lectures of my colleagues. Have a great day.